Hello everyone, I am Dr. Anupama Chowdhry Devgan, your physiology faculty. Now, this is physiology in small doses. So I have been putting up a quiz, especially for my FMGE students, on my Telegram channel. This is a quiz of 10 questions. It's a mixed bag of 10 questions. This I put up every alternate day, and the video solution will be available on the YouTube channel, on my YouTube channel at 10 p.m. on the same day. So this is quiz number 2. Now, let's have a look at the first question of this quiz, and this was: contraction of the fundus of the uterus during labor causes cervical dilatation and eventually delivery. Which of the following shows a similar regulatory mechanisms? Now, you know that there are 2 regulatory mechanisms. These regulatory mechanisms could be negative feedback or they can be positive feedback. Now, the process of delivery or parturition is an example of a positive feedback mechanism. See, what happens in positive feedback is, because of the contraction of the fundus of the uterus, the fetal head is pushed downwards. This causes a cervical dilatation, and cervical dilatation enhances the uterine contractions, which causes the fetal head to be pushed downwards, more cervical dilatation, which further enhances the uterine contractions. So this is an example of positive feedback. Now, the examples of positive feedback are very few, in fact. Remember, CLAP. C is clotting. C also stands for calcium release from the sarcoplasmic reticulum during a muscle contraction. These are examples of positive feedback. L is LH surge. L is also the milk let down reflex. A stands for the action potential. It also stands for the activation of inactive pancreatic enzymes to their active form. And P is for parturition, the process of delivery, which I just described to you. If you add S, claps, shock is also an example of positive feedback, but what kind of a shock? The uncompensated shock or a decompensated shock is an example of positive feedback. So going back to my question, which is another example of positive feedback, let's have a look. Secretion of T4, T3 by thyroid gland. Secretion of most hormones is by a negative feedback mechanism. Action of ADH on collecting duct of the kidney, negative feedback mechanism. But the milk let down or the milk ejection reflex is a positive feedback mechanism. Secretion of FSH is also by a negative feedback mechanism. So answer here is C. Insulin-dependent GLUT4 is an example of which of the following mechanisms of transport across the cell membrane? GLUT is glucose transporter. This is an example of facilitated diffusion. Primary active transport, an example, the sodium-potassium ATPase pump. Secondary active can be secondary active co-transport, secondary active counter-transport. Simple diffusion, respiratory gases, lipid-soluble substances, alcohols, they move by simple diffusion. But GLUT, glucose transporter, is an example of facilitated diffusion. The next question. A patient with an HbA1c of 11.4%, so this is definitely uncontrolled diabetes, has come to your clinic with severe pain in his feet at night. Which nerve fibers are involved in this patient? Now, pain fibers are A delta and C. These are your pain fibers. Here is a patient complaining of severe pain because you know in uncontrolled diabetes, neuropathy is very common. So In this case, my answer becomes type C. Sodium chloride co-transport. Sodium chloride co-transport is an example of secondary active co-transport. This is seen in which part of the nephron? This is going to be seen particularly in the DCT, and there is a diuretic which acts on the Na plus Cl minus co-transport, and that is thiazides. Now let us see what are the examples of sodium reabsorption in the PCT. By secondary active co and counter transport. Which are the co-transports? Sodium glucose co-transport, sodium amino acid co-transport, sodium phosphorus co-transport. Counter transport will be sodium H plus counter transport. In the loop of Henle, the descending thin segment, there is no sodium absorption, only water is absorbed. But in the thick ascending limb, you have Na plus K plus 2Cl minus co-transport. A diuretic which acts on the thick ascending limb, this is Lasix. Loop diuretics. Collecting duct. For sodium reabsorption, we have epithelial sodium channels. And the absorption of sodium in the collecting duct is under the control of aldosterone. So this is briefly about how sodium is going to be absorbed in different parts of the nephron, but the Na plus Cl minus co-transporter is present in the DCT. And a diuretic acting on this is thiazides. Let's see the next one. Identify the event taking place in the intestine. Now here you are shown a segment of intestine, and as you can see, there are alternate contraction and relaxation in a segment of intestine, right? And because of this alternate contraction and relaxation in a segment of intestine, it causes mixing. And these are your segmentation contractions, right? These are your mixing contractions. Now, what is peristalsis? In peristalsis, there is a ring of contraction behind the food and relaxation in front. So what happens is the food is pushed forwards. This is meant for a forward propulsion of food. So here the answer is segmentation. Now, passive diffusion is not a contraction. So this is definitely not the answer. Basic electrical rhythm is an electrical event, not a mechanical event as shown in this diagram. So that is not the answer. So let's have a look at the next question. Now this says, which of the following hormones can regulate release of prolactin from the anterior pituitary? Now remember, the secretion of prolactin from the anterior pituitary is controlled by prolactin inhibiting factor from the hypothalamus. And what is this prolactin inhibiting factor? Nothing but dopamine. Prolactin inhibiting factor decreases prolactin secretion. There is another hypothalamic hormone which can increase prolactin secretion, and that is TRH. Right? So the answer to this question becomes pretty simple. It is thyrotropin releasing hormone. Now let's apply this clinically. Now in a patient of hypothyroidism, there is decrease in T4, T3 from the thyroid gland, which in turn causes an increase in TRH from the hypothalamus and TSH from the anterior pituitary. Now because there is increase in TRH, it will also increase prolactin secretion. So galactorrhea may be seen in a patient of hypothyroidism. Galactorrhea is milk secretion from the breast. So that means if you have a non-pregnant woman presenting with galactorrhea, please get the thyroid profile done. This may be a case of hypothyroidism. Before you tell the patient that you have a prolactin secreting tumor and a prolactinoma and you have to undergo surgery, etc., 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 first get a thyroid profile done. It may be a simple case of hypothyroidism. Let's look at the next question. Which of the following is correct about the JVP? JVP is measured from the xiphisternum? No. JVP is measured from the angle of Louis. That is the angle between the manubrium and the body of the sternum. V wave occurs in isovolumetric contraction. That is not true. What occurs in isovolumetric contraction is the C wave. Upper level of JVP rises? No, it falls with deep inspiration. If it does not fall with deep inspiration or rises, then we call it Kussmaul sign. And Kussmaul sign is typically seen in a patient of constrictive pericarditis. Why descent occurs in the first rapid ventricular filling phase, which is true. The A wave of JVP is due to atrial contraction. C wave of JVP is due to bulging of the closed tricuspid valve into the right atrium during isovolumetric contraction phase. X descent, a downward pull of the closed tricuspid valve during the phase of ejection. Then another positive wave, which is the V wave, due to venous filling of the right atrium just before opening of the tricuspid valve. Where the tricuspid valve opens, now the blood will flow from the right atrium into the right ventricle, and that gives rise to a negative wave, which is called the Y descent. So Y descent occurs in the first rapid ventricular filling phase. Next question, what is Brown-Sequard syndrome? Brown-Sequard syndrome is a hemisection of the spinal cord. Now, what is hemisection? So if I look at the spinal cord, half of the spinal cord has been cut, right? So that means the descending motor pathways on that side cannot reach the lower part of the spinal cord. And similarly, the ascending sensory tracts cannot ascend upwards to the cortex. So that means it leads to damage of ascending sensory and descending motor pathways. Let's see the next one. A child is brought by his mother with complaints of weakness and difficulty in walking from childhood. He is unable to climb stairs. She also states that he is not able to do day-to-day activities. Upon inspection, his calves are bilaterally hypertrophied. This is a typical clinical condition of Duchenne's muscular dystrophy, where there is severe proximal muscle weakness. Remember, in Duchenne's, dystrophin is deficient. D for Duchenne, D for dystrophin, and D for deficient. So there is absence of functional dystrophin. There is another clinical condition which is called Becker's. In Becker's, dystrophin is present but reduced. Remember, Becker is better. Loss of function mutation of titin gives rise to a clinical condition which is called tibialis muscular dystrophy. Mutation of the ryanodine receptors gives rise to a clinical condition which is called malignant hyperthermia. Mutation of the connexin proteins gives rise to a clinical condition which is called Charcot-Marie tooth disease. Now let's look at the next question. A 60-year-old man with a history of COPD undergoes arterial blood gas analysis, which shows increased PaCO2, that means there is CO2 retention, and a decreased PaO2, that means a hypoxemia. He is given oxygen by a face mask, after which his respiratory rate, in fact, decreases. What is the explanation for this? Now remember, hypoxia stimulates the peripheral chemoreceptors. Which are the peripheral chemoreceptors? These are your carotid and aortic bodies. And when these chemoreceptors are excited, they will send impulses to the respiratory center, and there is an increase in the rate and increase in the depth of ventilation. But if the PO2 levels are high, they start inhibiting the peripheral chemoreceptors and suppressing the respiratory drive. So there is a depression of the peripheral chemoreceptors due to increased PaO2. Why not option A? Now please remember, hypoxia does not affect the central chemoreceptors. It affects only the peripheral chemoreceptors, carotid and aortic bodies. Stimulation of the stretch receptors of the lungs causes a decrease in the depth of inspiration. It does not affect the rate. Increased sensitivity of baroreceptors. Baroreceptors have nothing to do with regulation of respiration. So this answer to this question is there is a depression of the peripheral chemoreceptors due to increased PaO2.